alaikum. Good afternoon, everyone. Thank you to Abdullah, Dr. Musa for the nice introduction. This is too much for me. And I'm going to speak today about the challenge of managing heart failure with preserved ejection fraction. So what's HFpEF? The classic definition of HFpEF is, in Brownell textbook, is the inability of the heart to pump adequately at normal filling pressure in patients with EF of 50%. But the ESC came up with this universal definition, which is composed of 3 criteria. The first one, there must be symptoms and signs. EF should be more than 50%, and there must be objective evidence of structural, functional, cardiac abnormalities in the presence of elevated natriuretic peptides. And HFpEF is actually an epidemic, so the proportion of patients with HFpEF is increasing over decades, and this is a study, data from Framingham study, which showed that over 3 decades, patients with HFpEF, which shown here in the red bars, are significantly increasing over the time. And this is recent data from US. So patients with HFpEF account for almost 52% of patient heart failure in the US, with an annual increase of 1% if you compare it with the HFrEF, heart failure with reduced ejection fraction. And the gap is expected to increase because of the aging population. And those, remember always that HFpEF is a disease of comorbidities. So most patients with HFpEF are having comorbidities. So acquiring comorbidities over the time make those patients predisposed to HFpEF and develop the disease. And remember that 70% of patients with HFpEF older than 65 years, 70% of patients with heart failure above the age of 65 years are HFpEF. And this is outcome of patients with HFpEF in the EC heart failure registry. It showed that if we compare it with patients with HFrEF, mortality rate and the heart failure hospitalization is still lower than HFpEF. So HFpEF mortality rate and hospitalization is still lower than the HFrEF. But remember, this is an outpatient. This is not a hospitalized patient, this is outpatient. But if you come to the hospitalized patient, this is data from Mayo Clinic, elderly patient who's been hospitalized. And the curve here, you can see this overlapping curve between, this is a mortality rate over 5 years. The curves of HFrEF, HFpEF, and middle range, they're overlapping over 5 years. And you can see by the end of 5 years, it's almost touching 80%. So there's a considerable mortality risk in patients with HFpEF. So I guess heart failure, regardless from the cause of heart failure, is associated with a very significant level of mortality. And heart failure, so HFpEF is a disease which manifests with non-specific symptoms. Patients come with dyspnea, fatigue, which might be attributed to other reasons. But there's some clues for patients with HFpEF. So remember that patients with HFpEF always having comorbidities, at least on the average, patients with HFpEF having 2 to 4 comorbidities. And one of the most common comorbidities is obesity. So obesity contributes to 80% in patients with HFpEF, and hypertension 60 to 80%, diabetes 20 to 45%. Also, which is not mentioned in this image, is chronic kidney disease, AFib. AFib is very common in AF, whether during the course of the disease or to start with, and patients with coronary artery disease as well. So diagnosis of HFpEF is sometimes challenging, and that's why from Mayo Clinic this score was proposed to make the diagnosis of HFpEF easily and to increase the awareness of HFpEF in the community. So this is composed of 6 variables. Each variable has a credit, has a point, give it some points. So for example, it's called HFpEF. So it is, H2 stands for heavy, which is body weight, body mass index more than 30, and hypertension, using of 2 antihypertensive drugs or more. AFib, take 3 points. Pulmonary hypertension 1, elder 60, above age of 60 years, take 1, and filling pressure as measured by the Doppler E prime ratio in the echo. So it takes only 1. So this is scored total points of 0 to 9. So if you have a score from 0 to 1, you can rule out the disease with some certainty. And if it is more than 6, you got the diagnosis of HFpEF. But if it's intermediate between 2 to 5, you need a confirmatory test, which we're going to talk about in a minute. And a year later, the AEC came up with a new algorithm, which is called HFpEF. It's a bit complicated than the other one, and it's composed of 4 steps. The first one is, so P stands for pre-test assessment. So it's clinical examination, comorbid condition evaluation, and ECG, and so on. And E stands for, the second step is echocardiography, which is a comprehensive echocardiography, plus testing the natriuretic peptide. And the F1 stands for functional testing. So in patients with an intermediate risk in any of the two scores, if it's having intermediate score, you go for stress test, which we're going to talk about it, and finally etiological workup, which is a final etiology. So final etiology means that not all patients with HFpEF are truly HFpEF. There are some diagnoses which we're going to talk about also. So this is step number E. So step number P, we said the preclinical assessment, clinical assessment, and the step E is a cardiology. It's sophisticated and complicated. We're going to just mention it quickly. So there are two form of evaluation: major criteria, minor criteria. The major, both of them compose of functional assessment. Functional assessment means that the diastolic dysfunction evaluation by echo, the classic evaluation. Morphological assessment, it is basically left atrial enlargement, left ventricular hypertrophy, and biomarkers, natriuretic peptide, or PNP or pro-BNP. And remember one thing, that in patients with AFib, the cutoff value for pro-BNP and BNP is 3 times the patient who is not an AFib. So keep this in mind when you make the diagnosis. Both of those scores were validated in a relatively small number of patients, but it's been published in the European Journal of Medicine. And so let's go to the third step, which is if you have an intermediate course, what are you going to do? So intermediate score. So there are 2 types of stress tests. One of them is the echo, so cycle ergometry while doing the echo, and you check 2 things. You check the filling pressure measured by the E prime ratio, and the tricuspid gauge with the pulmonary artery pressure. So if it increases above, if the E prime ratio increases above 15, or the tricuspid velocity increases above 2.8 meters per second, this is HFpEF. So you got the diagnosis. So in patient with intermediate score, vague symptoms, you're not sure about, he's not fulfilling the criteria for the score, you go for a stress test, echo stress test. The other way, which is the gold standard, is the invasive measurement, which is through in the cath lab, so measured with hemodynamics. As you see here in the upper panel, you can see patient at rest. This is the left ventricular pressure tracing, low diastolic pressure at rest, and when he starts to exercise in the lower part of the image, you see that the end diastolic pressure increased significantly, and if it is increased more than 25 millimeter mercury, this is HFpEF. So when you get the diagnosis, now you should think of etiological workup. Why this patient is having heart failure? So this patient is having heart failure with normal or preserved ejection fraction. So there might be some other reasons. And remember, there might be infiltrative disease, pericardial disease, or restrictive heart disease. And actually, if you see one patient echo with a septum of more than 16, this is most probably diagnosis different than HFpEF, could be infiltrative disease. Just keep this in mind. Again, not all HFpEF are HFpEF. And this is an example of this. So this is a patient who was complaining of symptoms and signs of heart failure. His EF is normal. He went for hemodynamic study. The red curve is the left ventricular pressure. The blue is the right ventricular pressure. And at the third beat during inspiration, you can see that the left ventricular pressure goes down, RV pressure goes up, and on the still frame, you can see extensive calcification of the pericardium. So this is a patient with constricted pericarditis, and this hemodynamic data, we call it interventricular independence, which is a sign of pathognomonic of constricted pericarditis. So this patient will not benefit from medical therapy. He should go for the surgeon for a pericardectomy. And this is another lady, 70 years old. She's having some signs of heart failure, normal ejection fraction, but she's having macroglossia, and she's having apple green birepharyngeals on the tissue biopsy. So this lady is having amyloidosis. And again, why is this important? Because those patients are having now a specific treatment. That's why it's very important and crucial to pick this patient and to diagnose them in the right way. So this is the list of patients who with HFpEF, which seem to be HFpEF, but they are not HFpEF. They're like amyloidosis, sarcoidosis, congestive pericarditis, and so on. It's very important to remember this list while making the diagnosis. And on the other hand, sometimes HFpEF is disguised. So this is a lady who's 81 years old, shortness of breath, normal EF, RV pressure 75 millimeter mercury. So she was referred from the pulmonary hypertension clinic for right and left side cath. And you can see here the blue curve is the right atrial pressure, the red one is the pulmonary capillary wedge pressure, while the green is the pulmonary artery pressure. And you can see that the pulmonary artery pressure is very high, and the wedge pressure is also high. And once she took 2 micrograms of sodium nitroprusside, you notice that the wedge pressure came down and the PA pressure came down. This is HFpEF. And when you try to give this patient nitric oxide as a form of vasoreactivity, So look what happened. The red curve, which is the pulmonary capillary wedge pressure, increased substantially, and it might go into pulmonary edema. That's why pulmonary vasodilators are not indicated in HFpEF. Two caveats here: that a patient with pro-BNP, remember that 20% of patients with HFpEF are having normal pro-BNP, and 30% are having normal or less than 200. So this might make you confused. And remember one more thing, that obese patients are having lower level of pro-BNP than non-obese patients. And this is for some reason because adipocytes are having enzymes called neuroendopeptidase, which increase the metabolism of pro-BNP. The other thing is EA ratio is it's a very good tool, but remember it's not always useful, because sometimes, as you see on the right side of the graph of the image, that this is the correlation of the EA ratio for patients with non-cardiac dyspnea versus HFpEF. There's a big difference, definitely, and with a significant p-value. But if you look at this, the lower shaded area, if you can see the green one, you can see that there is a considerable number of patients with HFpEF are having values below what we consider to be abnormal. So EA ratio is a good tool, but it is specific, but it's not sensitive. And it's not a rule-out tool. You cannot rule out HFpEF with this. So do we have treatment for HFpEF? So all the studies which have been done over the last 2 decades trying to find a treatment for HFpEF, ACE inhibitors, ARBs, ARNI, spironolactone, digoxin, and so on. And none of them show actually any benefit, although some of them show some promising results, but technically they failed. And here the CHARM study, which tested the candesartan over a wide spectrum of ejection fraction. It was successful in patients with HFrEF, patient with mild reduced ejection fraction, but it failed in patients with HFpEF on the left side of the slide. And also the TOPCAT, which is spironolactone in patient with HFpEF, it was basically patient with EF 45% in NYHA class 2 to 4, previous hospitalization, and the primary endpoint was cardiac death, hospitalization, and aborted sudden cardiac death. And also, spironolactone failed to show benefit in the primary outcome, but at the level of the hospitalization, which was a pre-specified secondary outcome, it showed a significant difference in hospitalization. And if you notice on the left side of the graph of the slide, that the curve, which is the black curve, the black solid curve, this is the hazard ratio, the continuous treatment effect of the hazard ratio. So you can see that it reached the level of the 1, which is the neutral effect, at ejection fraction of 60-65%, which means that there is attenuation of the effect of spironolactone over the range of ejection fraction. That's why spironolactone is taking 2B, class 2B in the guidelines in patients with HFpEF. And finally, the Paragon heart failure, this is the most recent one. It's skibitril, valsartan versus valsartan in patients with NYHA class 2 to 4 for more than 4,500 patients, elevated BNP, and the outcome was hospitalization and cardiovascular death. And Paragon just missed its primary endpoint with a p-value of 0.06. But there is, in subgroup analysis, there was 2 significant interaction at the level of the sex and ejection fraction. So if you see here, at the level of the sex, the female, there was a 27 relative risk reduction in female, and at the level of ejection fraction, there was 22 relative risk reduction in patients with ejection fraction 57 or less. People are saying that diuretics doesn't have a real data, but this data from the Champion study. Champion study was a study for patients with heart failure, all-comers heart failure, all ejection fraction, and they put a device, which is a pulmonary artery pressure sensor, inside the pulmonary artery to measure the pulmonary artery diastolic pressure. And you know the pulmonary artery diastolic pressure is almost equivalent to the pulmonary capillary wedge pressure. And through a telemonitoring, this data was transferred to the treating physician, and he adjusts the medication according to the increase or the change in the pulmonary artery diastolic pressure. So if the pressure increases, this means the patient might increase diuretics or use another form of diuretics, and so on. So surprisingly, this data is from the patient with preserved ejection fraction, so about 200 patients. And you can see almost 50% relative risk reduction in decreased hospitalization in patients with HFpEF over 18 months, with a considerable difference between this patient and the other study, and the other studies like CHARM and iPreserve and TOPCAT. This is the picture of the device. So recommendation for patient heart failure at this stage was only diuretics and control of the risk factor at that moment.
Dr. Farooq, 2 minutes, please.
Okay, so I'm going to go through this quickly. So, finally, we have SGLT2 inhibitors. This was recently published over the last 2 years. We have Emperor Preserved, Deliver. Both of them show very significant difference in significant effect in heart failure and hospitalization. And this has changed the guidelines. And for the first time, we had an evidence-based medicine, which is SGLT2 in patients with HFpEF. And it was given a class 2A in the American Heart Association guidelines. The EC guidelines, I guess it will be changed soon. AFib is very crucial and very common in AFib and HFpEF. Treatment of atrial fibrillation might help, and there's some recommendation for consideration of cardioversion or conversion to sinus rhythm. And this was shown in Cabana study, where catheter ablation showed some benefit in patients with AFib regarding hospitalization and cardiovascular mortality. But this was subgroup analysis and in patients with HFpEF. Exercise training is, people are pushing toward exercise training. It's really effective, but the study is only limited for soft endpoint like peak VO2 consumption. Weight loss is very important with some also good data. And there's some new study using semaglutide, which is a GLP-1 agonist, in treating patients with HFpEF, which is on the way, probably will be published next year. So take-home message, HFpEF is a real heart failure syndrome. It's not simply the historic dysfunction. And HFpEF patient has some specific phenotype. They're usually having comorbidities. They're elderly, obese. And diagnosis of heart failure, HFpEF is sometimes challenging, but the probability score we just mentioned can help. Therapy targeting neurohormonal activation and nitric oxide pathways have failed in HFpEF, with some arguable exception like MRA and ARNI. SGLT2, the first inhibitor, is the first evidence-based medicine in HFpEF, but probably not enough. Exercise training and weight loss should be considered. Consider restoration of sinus rhythm and consider revascularization of coronary artery disease. Thank you.